Welcome to the 2022 Head and Neck Cancer Survivorship Symposium, developed by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session is titled Head and Neck Cancer Survivorship and Aging. I am Dr. Nirav Goyal, an Associate Professor of Otolaryngology, Head and Neck Surgery, Neurosurgery, and Public Health Sciences at the Penn State Cancer Institute. I want to thank our medical panelists, Dr. Susan McCammon and Dr. Marci Lee Nilsen, as well as our survivor panelist, Kristi Molnar, for presenting on this session today. To begin, I'd like to provide a brief introduction of each of our panelists. Our survivor panelist, Kristi Molnar, was diagnosed in 2007 with an oropharyngeal squamous cell carcinoma of the right tonsil. Her treatment included chemoradiation with the inclusion of cisplatin as well as Erbitux. The majority of her professional career was spent in the financial services industry and as an executive officer for a West Virginia bank holding company. After retirement, Chris was hired as an executive director by a nonprofit organization that works with pre-hospital professionals in West Virginia. For many years, Chris was fortunate to also lead the board of a local hospital corporation and has been very involved recently with a regional community foundation as its president. Dr. Marci Lee Nilsen is an assistant professor at the University of Pittsburgh School of Nursing in the Department of Acute and Tertiary Care with an appointment in the School of Medicine, Department of Otolaryngology. Her research program focuses on identifying and managing symptoms and treatment-related effects in head and neck cancer survivors through the development of interventions targeted to meet the unique needs of this patient group. She was also integral to the development of the UPMC Head and Neck Cancer Survivorship Clinic, and now serves as its co-director with Dr. Jonas Johnson. Through the clinic, Dr. Nilsen and the multidisciplinary team of healthcare professionals take a patient-centered approach to addressing the issues and needs of persons with head and neck cancer across the survivorship trajectory. Dr. Susan McCammon is the director of the Division of Head and Neck Oncology at the Department of Otolaryngology at the Heersink School of Medicine in the University of Alabama at Birmingham. She is board certified with the American Board of Otolaryngology, as well as the American Board of Internal Medicine, Hospice, and Palliative Care. Her areas of interest include head and neck surgical oncology, as well as surgical palliative care. Thank you to all of our panelists, and we'll start with Kristi Molnar.
Good evening, everyone. My name, as you've been told, is Kristi Molnar, and I am a 15-year plus cancer survivor. There are a couple things that I think are important that you know about me. And one is that I am doggedly perseverant, and I am filled with joy, and joy because I've had the opportunity to live a wonderful life, one of healthcare advocacy that my husband and I share and work diligently to help not only me through the process, but others. My road started from a misdiagnosis, and that's how I came to UPMC. I was fortunate the first day I met Jonas Johnson. He said, "You have garden variety cancer," and immediately sent me to a radiation oncologist and a medical oncologist. And within a couple hours, we had the program planned, went through it for 2 months, lived in Pittsburgh, and came home pretty darn weak and tired, but ever grateful that I knew I had a long life ahead of me. I want to talk about a few things that have come along the way and things that we have done to make certain that I make the best of this life that I have. One being dental treatment. You all know as well as I do that when you go through this, saliva is kind of challenging at times, which can lead to gum disease, really significant dental problems. I went to my dentist who completely understood. He gave me fluoride varnish. I would see him every 3 months, and then he bonded my front teeth because they were becoming translucent. I continue to see my dentist now every 4 months. I am diligent about dental cleaning and dental health. As you can probably tell from the way I speak, my saliva is still a challenge. I pretty much tried all the over-the-counter things. I've been in a couple programs to try to help UPMC with understanding opportunities for saliva treatment, none of which have really helped me very much. So at times I have trouble speaking. My gums stick to my lips. I do have trouble eating at times, and ranch dressing has become my very best friend. So that helps me a lot. A few years ago, I was lucky enough to be able to go to the Survivorship clinic. And there I met Jonas Johnson and Marci and all the experts that are at UPMC Survivorship Clinic. One of the things that I determined talking with people there is that my mouth didn't open wide enough. So Karen, the physical therapist, and I worked with tongue depressors opening my mouth, and she manipulated the inside of my mouth to help the scar tissue, and I was able to eat a hamburger again, which was my objective. I have really been fortunate to have excellent health. There was one thing I forgot, and that's that my hearing is somewhat challenging. I have ringing in my ears 100% of the time, but most of the time I choose to ignore it. And I had hearing aids, but one of our dogs ate one of them, and I have yet to have them replaced. On August 27th, very early in the morning, I woke up on the floor next to our bed here at home. And I said to myself, geez, I could get up off the floor more easily last night than I can tonight. And then I realized something was wrong. Well, I had a stroke. And the EMS person who came, his name was Ed, and he is one of my angels. He said to my husband, we're taking her to UPMC because if we take her to the local hospital, she's going to end up coming out of there just like she went in. So I was life flighted to Pittsburgh, and I felt comfortable because all my treatment had been at UPMC. I felt like I was home in some respect. I was well aware of what was going on. I knew there were issues that I had, but I was certain that it would be okay. So I arrived at Presbyterian Hospital. They looked at me and said, you're not a candidate for the clotbuster. You've been gone. It's been too long, but boy, do we have something we can take care of for you. So they put a probe up through my groin. I was awake during this procedure. They went up into my brain and removed the clot and put a stent in my carotid artery. So I was in the ICU for a few days. I had some paralysis initially, came within 18 hours, it was gone. When I was in the ICU, like I always do, I asked 1,000 questions. And I said, what caused this? And they said, the scar tissue around your carotid artery. So we talked about it at length, and they tied it to the radiation treatment I had had 15 years previously. And I kept thinking, gosh, I wish I knew about this. I wish I could have anticipated that it would happen. And I had no clue. And I'm the kind of person who needs to know. I had no signs. The day before it happened, the day it happened, we were getting ready to go on a trip to France. And I was running up and down the steps, and I thought, geez, my neck hurts, but that was it. Nothing significant. And so what I did was as I do in everything, I believed that I was going to be okay. In fact, I had a sign that I was going to be okay. When they were operating on me, I was laying on the table. I had to be awake. And I saw myself above in this light that shined down on me. And it was like I was above watching myself. And I said to myself, it's going to be okay. And I was like, oh, good, it's going to be okay. And I believed that. It's 11 months almost since I had my stroke. I'm 100% back to where I was before, and even stronger because of all the exercises I've been doing. And I'm very happy to be here. I'm very happy to share my story with you. It's been a road of dogged perseverance and joy. I have gratitude for my entire life, and I want to share that gratitude with others. So with that, I'll turn it over to Marci, I believe.
Thank you for sharing your story, Christine. I really appreciate it. And I think it highlights some of what we're going to discuss during our presentation. And next slide, you can put it up. And just how, for many of you, you've gone through treatment, you've been cured, or some of you maybe have had multiple treatments. And so now you're living with the effects of your treatment and your cancer, but you're also aging. And we do have a larger portion of head and neck cancer survivors. So we know that head and neck cancer really accounts for about 4% of all cancers. And currently the prevalence or the amount of head and neck cancer survivors is rising. There's several reasons why. Some of it's our treatment advances, and some of it is that we now have HPV-related head and neck cancer, which is highly curable. And these patients will have, or maybe present younger than our traditional patients, and they will live longer with the side effects of their treatment. And so really, the point of this talk is to highlight what may occur as you age after your treatment, and what may be aging and what may be cancer, and how do they mix together, giving you points and highlights and things to consider throughout your journey. Next slide. So we do have some guidelines. So Chris in her last visit came and we discussed how do we look at survivorship and how do we really plan? And so some of it is based in evidence and research, but because patients historically have not survived as long as they do now, some of the guidelines are really based on consensus and not really strong clinical trials. But we do use these, and these guidelines have primarily been designed for primary care providers, but oncologists also use them. And they cover several points. The American Cancer Society Head and Neck Cancer Survivorship Care Guidelines were the first. The American Society of Clinical Oncology has added to it. And the Head and Neck Cancer, the American Head and Neck Cancer Society has also further made comments on what we should do. But in general, these guidelines are very similar. We should surveil for recurrence. So we should look to see if your cancer is coming back. We should screen for second primaries in your head and neck, but also potentially in your lung. And this is one that we really will focus on throughout the talk, the assessment and management of physical and psychosocial long-term and late treatment effects. Health promotion, how can you maintain a healthy lifestyle and really try to minimize or mitigate some of these changes that may be age-related, gender-related as you go through your trajectory. And then care coordination is really just how can we help you get into these appointments, get to where you need to be, and how can we discuss as providers with your other team, either your oncology team or your primary care providers. Next slide. So this kind of goes at the end, but I want to talk about it first. So health promotion. So many times when you're going through treatment, you're really focused on being around your oncology team, but it is important that you continue to monitor and meet with your primary care provider, because they are going to be able to offer you more age-appropriate, gender-appropriate screening and recommendations. And it's very important, even from the beginning, that you see your primary care provider, because there have been data and studies that have shown that patients come in, maybe their blood pressure isn't under control or their cholesterol is high, and all of those things are good to start to address early so we can potentially mitigate or minimize some of the things that you may be at risk for. Healthy lifestyle, so diet. I know many patients, it's not that you have to lose weight after cancer treatment, but put it on, and we make sure you want to put it on in a way that is healthy, which is just really working with a dietitian, coming up with the plan, but also remaining active as you physically can. Smoking cessation and limiting your alcohol, and then evaluating your thyroid function if you've had radiation. We recommend, the recommendations are drawing those blood levels, so your primary care doctor or your oncology team may send in a script to draw those every 6 months to every 12 months. Next slide, please. So surveillance. So I highlight this because it does showcase your journey. So in the beginning, you're very familiar with surveillance or watching for those recurrences and second primaries. A detailed cancer history should be taken. A physical exam should be done. It's commonly done by your otolaryngologist or your head and neck surgeon or one of your oncology specialists. Next. Now, this is really in the beginning very close because we know that if you're going to have a recurrence, it's going to happen within the first 3 years. So, and this may vary a little bit by your institution, but in the first year, you're going to be seen every 1 to 3 months. The second year, every 2 to 6 months. And then 3 to 5, it spreads out a little bit more, every 4 to 6 or 4 to 8. And then at 5 years, it could be annually, and some institutions may not follow you annually. It really depends on your team. The important part with this is that as you progress, you are seeing your oncology team less and less. It's important to know what signs or symptoms that you should self-monitor for to be able to come back in. And this is not just for signs of your cancer coming back, but also some of these other things that we're going to talk about. You should be able to know what are problems and what are signs to come back. It's kind of self-monitoring and even self-managing once you keeping up with your exercises. And even during that, if something changes, you should know the difference. And so in that time when you're not being seen as frequently, it can cause some stress, but you should be prepared and know what to look for and monitor for. Next slide. So what are late and long-term treatment effects? It is technically different. So long-term things are things that start during radiation or during treatment, and they persist. So this could be neck and shoulder mobility. That could be from surgery or radiation. Xerostomia, which is dry mouth. Dysphagia, again, could be from surgery or radiation. Lymphedema, fatigue. Now, late effects are things that are sometimes harder to pick out as being related to your cancer or its treatment. They start after treatment ends, and it can be months to years after treatment ends. These could be the neuropathies, like neuropathies in your hands, tingling in your fingers or toes, cardiovascular disease, hypertension, trismus, which is difficulty opening your mouth, hearing loss, and cognitive changes. And so these are just few examples. There are more that fall into both of these categories, and sometimes they can be in either one, just depending on when they start. Next slide. So what are comorbidities? This is another thing. So a lot of terms that you may hear. So next. Comorbidities are 2 or more health conditions or diseases that can occur at the same time. And so this may be a word that you've heard from your primary care doctor. Some people may have hypertension and diabetes, or hypothyroidism and high blood pressure. So there could be combinations. And so this may or may not be a word you've heard. Next. So we do know that sometimes especially older adults, as you're getting diagnosed with cancer, you may have more than one of these. And when you have more than one, it does predict, it is more likely that you'll have others, which is why it's important to contact your primary care provider from the beginning and stay connected. Now, what do we see in this? We see patients that may have treatment-related comorbidities, such as hypertension, dysphagia, again, just trouble swallowing, which can go with weight loss and malnutrition. Dental issues, depression, they do tend to rise over time after you're treated. Next. So it's really important to know these things, and we're going to try to highlight these more as we move on through the slides. And there are resources that you can utilize from different organizations to help you better understand and know what you're looking for. And again, American Cancer Society's guidelines are available. The American Society of Clinical Oncology are available. These are not things that you have to pay for. They are available online. So now I'm going to pass the conversation on to Dr. Susan McCammon to really discuss more individually some of the things that we see as you age after your head and neck cancer treatment.
Thank you, Marci. That was a great introduction. So I want to really focus on the relationship between normal aging as a patient without cancer and aging as a patient with cancer. So what are the late effects of your cancer? You have been surviving this cancer for a while as a young person or a middle-aged person, and now you may be an aging person. And you may have some conflicting messages coming from your body and from your primary care physician. So the questions are, what are the normal signs of aging? What is normal aging for anybody? And what are really late effects of your cancer? And importantly, how do these interact? Does your past cancer increase your risk of age-related issues? And can age effects and cancer effects be confused? And I think that as you get further and further out from your survival date, the more important these questions become. So the questions I want to ask are, what do you need to watch out for? And what does your primary care physician or your geriatrician, if you're moving into that specialized realm, need to know? Next slide. So dysphagia is one of the early and persistent signs and symptoms of cancer treatment. Causes are changes in swallowing structures, radiation-induced xerostomia and fibrosis, loss or change in dentition or trismus, change in opening of mouth. And we see signs and symptoms such as feeling like food is getting stuck in the throat or the chest, or coughing when swallowing food or liquids, and other new symptoms or subtle changes in your normal swallowing. Next slide. So is this aging or is this cancer? So cancer causes many, many things with dysphagia, but as you age, there are other things that affect your swallowing. General frailty, as you become more fragile, as your musculoskeletal system becomes weaker, your swallowing becomes a little bit more discoordinated, not necessarily to the point of not being able to swallow, but it can affect it. Aspiration, this is the bogeyman of both cancer and aging, that when you swallow, what you're swallowing goes into your lungs and not into your tummy. And then there are specific diagnoses in old age that can very much affect cancer, or very much affect swallowing, whether or not you've had cancer, such as Parkinson's disease or all of the many kinds of dementia. So what to do about this? And this is going to be a common theme throughout this, which is notice changes. And this has been true throughout your cancer survivorship. You have gone from an old normal to a new normal, and you're following that new normal along, and stable is good, change is of note. So notice changes. For dysphagia, you want to have a swallow evaluation by your speech language pathologist. There are therapies for compensatory moves, from chin tilt, head turn, many compensatory moves that can help with swallowing. Changing the texture of your food can improve swallowing. And there may be a point at which you need to consider or reconsider a feeding tube, which you may have had during your cancer treatment, but now may be offered in a different context as you age. And the offering of a feeding tube for cancer versus in old age is very different. So I think it's important, if you are beginning to talk about a feeding tube or replacement of a feeding tube as you're aging, to really consider what the reasons are for that. Next slide. Now I want to come to what Chris was so eloquent in sharing with us about the cardiovascular repercussions of cancer treatment. And stroke is perhaps the most dramatic, but myocardial infarction or a heart attack is also possible. But I'm going to focus on stroke here, which relates to the overt and then the more subtle injury to blood vessels, including the large vessels like the carotid, where you can have atherosclerotic plaque, which can fragment and give you a stroke, or radiation, which can cause both increased susceptibility to plaque, or stenosis, which can lead to decreased blood flow to the brain. That can cause an overt stroke. Small blood vessel damage can be related to diabetes or to tobacco use. And the signs and symptoms to look out for, again, notice changes. And for a stroke, the code word is fast. You look for asymmetry of the face, weakness of the arm, change in your speech, and time is critical because within the first 60 minutes, life-saving measures can be delivered. It's important to recognize mini strokes that resolve, which are called TIAs or transient ischemic attacks, because they are harbingers, are warning signs of more serious stroke symptoms to come. Next slide. So is this aging or is this cancer? Because everybody has some cardiovascular changes, and stroke and myocardial infarction are risks across the age spectrum. What is specific to your head and neck cancer treatment? So radiation effects include direct injury to the inside of the carotid artery. Later fibrosis, where things kind of scar in and squeeze the carotid artery, which results in stenosis, which is a narrower carotid artery in which any normal plaque becomes much more threatening or dangerous. So what do we do about this? So you want to be really diligent about cardiovascular health, diet, and exercise. Continue regular checkups with your primary care physician. Guidelines right now don't include carotid ultrasound as head and neck cancer survivor surveillance, but it may in the future. And again, notice changes and time is critical. Don't hesitate. If something like this is happening, you need to call 911, you need to call it now, and you need to say that you're worried about a stroke. Next slide. Hearing loss and imbalance. Hearing loss is one of the key things in aging. It can come from nerve damage related to age or chemotherapy. Cisplatin, which is a key chemotherapy for head and neck cancer, is notorious. But it doesn't have to come from permanent nerve damage. It can come from temporary ear obstruction from wax or eustachian tube scarring or fluid in the middle ear or a narrowed ear canal. And this can result in muffled hearing, like being in a barrel, harder hearing in noisy environments. If you have ringing in your ear, this may become more prominent as your hearing goes down, the ringing becomes more prominent, and you may have a full feeling in your ear. Next slide. So is this aging or cancer? Well, honestly, that's really hard to tell. Sensory neural hearing loss can be either. You may never distinguish. Obstructive issues are often related to radiation or surgery causing a narrow canal, dry skin, harder wax. And this may be a moment in which you need to seek an audiogram to test your hearing, a tympanogram to test the pressure or fluid in your ear, or regular ENT exams to clean your ear because the earwax may not clear itself as normally as it would do. As far as hearing loss, hearing aids are super expensive and may or may not be effective for survivors of hearing of head and neck cancer. There are cheaper and very effective amplification devices that we also advocate for. So next slide. Teeth. There is a whole different session on dental health, so I'm not going to recapitulate this, but when you think about aging in America, you often think about, the failure of your teeth, extracting them, getting dentures, getting implants, some kind of dental rehabilitation. What makes this more acute for head and neck cancer survivors? So the xerostomia or dry mouth, which causes a change in your good bacteria, and radiation in general causes a decrease in blood flow to the teeth, which means any operation, any instrumentation of your teeth is going to heal much more slowly and may not heal at all. And this can be a really big deal when you start looking at osteoradial necrosis. And you may see an increase in cavities, you may see an increase in pain or infection, receding or bleeding gums. Next slide. So is this aging or is this cancer? So radiation affects teeth forever. And the key piece of information for anybody who wants to work on your teeth is what your treatment, what your radiation fields were. Your treatment summary will describe the fields. Was it up here? Was it down here? Which teeth are actually at risk? Any treated oral tissue may be more sensitive to appliances such as partials or dentures or implants. Implants are always riskier because they involve operating on the bone where the radiation has impaired the blood supply. So what do you need to do? You need to make sure your dental provider knows you have had radiation, and you need to know that your head and neck team is aware that you're thinking of dental activity, because what the ideal is that these two teams will work together to make sure that you have a safe outcome. Next slide. Voice. Okay, so this is one of the key complaints in older geriatric patients in ENT as their voice is changing. And this is hard for head and neck cancer survivors because often voice change has been the, the harbinger or the canary saying, I have cancer. So any change in voice can be really stressful, but there are age-related voice changes that may be totally unrelated to your cancer. So this can be caused by changes to the nerves that move your vocal cords, the muscles that strengthen your vocal cords, any change in saliva or mucus, which causes a drier environment, any change in reflux, which causes a chronic cough. And the signs and symptoms we look for are a hoarse voice, a breathy voice, a weaker or softer voice. And often that becomes apparent when patients say they just tire out earlier. Like they used to be able to talk all day and now they can only talk for a couple of hours. And in extreme cases, it can result in shortness of breath where, your lungs just can't provide the power to your voice. And that can critically affect your voice. Next slide. So is this aging or is it cancer? So a fancy word, which sounds like a religion, but it's not, is presbylarynx, which is the aging larynx. And this is a picture of it where the vocal cords just kind of thin down. They're taking a break, they're retiring, and they don't meet as well in the middle. And that's pretty normal. So hoarseness or a weak voice can be a completely normal part of aging. There are neurological changes or musculoskeletal changes, which can result in a weakened voice. Or your lungs. If you are someone who has comorbid lung disease like COPD or emphysema, that can decrease the bellows strength of getting air to your voice. So what to do? Clearly, a scope exam is important to see if there's anything abnormal. And then speech therapy can help. And if you're really looking at an atrophic or weakened or, shrunken vocal cord, there are local injection therapies that can improve this. So it's important not to attribute it to cancer or age until you really know what needs to be corrected. Next slide. Finally, and we've worked through some of the easier and more superficial quality of life issues, and this is a big one, cognitive impairment. As we age, we all fear dementia and the loss of our neurological intactness. Cancer and cancer treatment itself can cause cognitive impairment, and this can collide with dementias related to age and what we used to call senility. So what causes it? So your tiny blood vessels, microvascular changes can lead to mini strokes. There are specific dementias like Alzheimer's and Parkinson's, which lead to changes in the way you think. You've all probably been introduced to the idea of chemo brain, which is a little fuzzy, but is real, but tends to be earlier in treatment. But there are research projects that look at cancer-related cognitive impairment without a real understanding of why it happens, but having had cancer and having had cancer treatment can lead to a more challenged cognitive environment. So what are these signs and symptoms? So word finding and short-term memory loss are really, really normal. Many, many people without dementia or cancer-related cognitive impairment have these, so don't panic. Loss of understanding of objects and functions or radical mood swings can be more ominous and should be attended to. Next slide. So is this aging or is this cancer? Again, notice changes and understand that here we may not ever be able to differentiate what is related to your cancer treatment, or your normal aging. What to do, don't panic. Follow with your primary care provider. Neurocognitive testing can help differentiate between regular, I can't remember that guy's name, to I'm not sure what to do with a fork. And understand that there are increasing medication and pharmacological options to help slow and decrease cognitive decline. Next slide. So now we will open the discussion to questions and answers from the audience.
Great. I just want to start by thanking our panelists for the excellent discussion, including our survivor, Ms. Molnar, as well as Dr. Nilsen and Dr. McCammon. So there are several great questions that I've seen in the chat, and I know Dr. McCammon wasn't able to stay on with the chat for too much longer, but I can answer the first question I see here from talking about saliva production. And so, as you heard in the chat and during the presentation, usually when we're talking about survivorship and saliva production, we're talking about dry mouth. We're talking about a lack of saliva production secondary to radiation. And it's important to know that the radiation typically or preferentially targets the saliva glands that make thin mucus. So each of your glands has glands that make thick mucus and glands that make thin mucus. And the ones that make thin mucus, the watery mucus, are the ones that are more susceptible to radiation. And so what we see in a lot of patients is that they're left with this kind of thick, sticky mucus. And the question asked about increased saliva production, and I've seen that in a few of my patients, and I know Dr. Nilsen had mentioned the same in her survivorship clinic. And oftentimes I'll see it in patients who have lymphedema or swelling. I know several of the panels earlier today I talked a little bit more about lymphedema, and sometimes with lymphedema, what ends up happening is the space behind the lower jaw ends up getting a little bit swollen, and so whatever little saliva you're making ends up coming out or ends up leading to drool. I know what Dr. Nilsen has suggested, and we've done this in our practice as well, is that we can recommend Botox for some of these patients where you can actually Botox the saliva glands to reduce the amount of saliva that they're producing. Anything that you'd like to add, anyone else would like to add about that question?
No, I think it's important for them to know too that a lot of ENTs will do it. So if you bring it up to your head and neck surgeon, they are likely to be able to facilitate somebody who does it. We have an ENT in our practice who does first bite and hypersalivation with Botox. So they are a good resource to ask if they know anyone.
Right. Yeah, definitely at an academic center, you'll find otolaryngologists that are doing Botox, so you won't have to find a different practice, different physician to help you with that concern. I do see another question on here that's talking about esophageal dysmotility and asking whether or not that's related to radiation. Would any of our panelists want to answer that question for our patients, for our survivors?
I think we do see it, and a lot of times patients, because of the way radiation works, we kind of assume that everything gets tighter, and so that things like esophageal dilation will work. But a lot of times it's really important to find out if dysmotility is really the answer and not just strictures. So having a good workup to ensure that's what what the issue is, working with a speech language pathologist, working with your head and neck surgeon, and maybe even consulting other practices to find the best potential mechanism for management.
Yeah, I think that's a great point. When we talk about dysmotility, much like Dr. Nilsen has suggested, you can think about a stricture. There's some sort of obstruction, and that can often be due to radiation. But what I've seen in my practice with our cancer patients is that the radiation causes, and I think much like Ms. Molnar had mentioned, the radiation causes changes to the muscles in the area as well, and you get fibrosis, and that's what sometimes leads to that dysmotility. So instead of the normal squeezing action that your swallowing apparatus is supposed to do, everything becomes almost like a lead pipe. And so, yes, I do believe, we do see patients for sure that have dysmotility due to radiation. It's usually the upper third if it's a head and neck cancer radiation. But as Dr. Nilsen had mentioned, really, you want to be seeing the appropriate provider that has that expertise. So, gastroenterology usually is much more attuned to managing the esophagus than the head and neck cancer surgeons, perhaps.
Yeah, that's typically what we do. Like, we may identify it, especially if we have if you do a modified barium swallow, or if they have you do an esophagram. And then once we see this, we typically rely on our gastroenterologists here, our cardiothoracic surgeons, to kind of take a look and see if there's anything that they can do.
Great. And yes, thank you. This is just a notification from our staff. If there are questions that we have not answered, please feel free to put them in the chat again. That's really what we're using to help identify questions. And I see a new question has popped up, and asking specifically about treatment-related strokes. Is there anything that my PCP can do to screen or identify if I could be at higher risk for treatment-related stroke? Or is it just standard diet and fitness? I'm happy to answer this as well, but Dr. Nilsen or Ms. Molnar, if you'd
I'll let you take it off, but I've got a thought. We were talking a lot about this before, but I'll let you take it off and I'll add to it.
Yeah, sounds great. Yeah, so I think that the things that we do in our practice that our radiation oncologists are very big proponents of is carotid ultrasound. So one of the things you have to remember with radiation to the neck, much like Ms. Molnar had discussed, is that you're going to get vessel changes, and really what we see with those vessel changes is vessel fibrosis. So carotid artery that started off this big, over time due to radiation effects can actually shrink down. So carotid ultrasounds are a great way to manage that. I can also look for plaques, and in most head and neck cancer practices, we're getting imaging at regular intervals, CAT scans or PET scans or MRIs, and those also let us take a look at the carotid vessels and really help with the screening component. I know there were some slides on here talking about the signs for stroke, and that's always a really important piece of it as well. To early identification is key in treatment. Please take it away, Dr. Nelson.
Yeah, so we've been talking a lot about this too, actually. And so a lot of the guidelines are, we don't have standard guidelines for watching. There's not, if we have somebody who has a history of smoking, we may do lung CTs, but we don't have that same protocol. But we do know that they can use the carotid ultrasound. When to start is still a little bit of a question. And so should we start early? What's the interval? So there's not exactly an answer. We're working with some of our stroke physicians here to discuss potential evaluation of some protocols. So something like aspirin, would that be beneficial? Or a statin? Those are some of the things that we use when people get symptomatic, but is there room for that earlier? So unfortunately, there are not really guidelines for prevention of the stroke. A lot of the activities or the interventions we do are after you become symptomatic, but it is something to consider with your PCP. Know your risks, and so they know your risks, and evaluate whether some of these things may be beneficial. So it's really good to continue with your primary care doctor, because they are going to be looking for some of these kind of lab work for your cholesterol. And so having the multidisciplinary team and kind of making them aware, and if you notice symptoms, report symptoms.
Great. I do see a couple of follow-ups about the same question. One was asking about the risk of a carotid stent in a radiated field, and the second one was asking about preventable medications for strokes. So at least for the second question regarding preventable medications, I think that's definitely a discussion to have with your family doctor, and they're going to be best suited to say, based on your risk criteria, based on different scoring systems that we have for strokes, this is what we would recommend for you. And I think you bring up a good point about doing any sort of surgery or any sort of intervention in a radiated field. There are increased risks associated with it. But again, it's a discussion that you have with your surgeon, with your physician that's going to be providing that service for you, because then they're going to be best suited to discuss, hey, this is the situation you're in. This is the risk that we are, potentially undertaking by doing an intervention, and these are the risks that we undertake by not doing an intervention. Unfortunately, these are areas that are not often black and white, and there's a lot of gray in making these decisions, and individualized treatment is key.
Yeah, and I agree. I think, one of the things that makes it different now is we do have head and neck cancer survivors who are living longer. So we are likely going to see more guidelines and more protocols related to these things because we have people living 10, 15, 20 years out. And so there's not a great answer on things to do prophylactically in terms of medication. But, you know, the two things that our stroke team talk about would be statins and aspirin. So those are things that you can talk with your primary care doctor. They're going to know your risk factors, and whether they're appropriate, they'll know your other medications, whether it should be something that you could take.
Great. So there's a question here about massage therapy for lymphedema. Dr. Nilsen, is there anything that you would like to add talking about that? Specifically, what are the best types for lymphedema and fibrosis?
So we like to, obviously, if you have surgery, we want to wait for the go-ahead from your surgical oncology team, 6 to 8 weeks usually. We typically don't do a lot of lymphedema, manual lymphatic drainage during radiation because people are uncomfortable. And there is some preference in the radiation oncology kind of realm and the providers on when to start. So typically we do start after. Once you started to heal and you can tolerate massage to your head and neck, you're going to want to look for somebody who's certified in lymphedema therapy. And so that's primarily speech language or primary physical therapists, but some speech language pathologists do have some certifications in lymphedema. They typically start with manual lymphatic drainage, so they'll do it, but they'll teach you how to do it at home. And then if your lymphedema is resistant to manual lymphatic drainage, that type of massage, they may recommend different compression devices, going from something like a strap, head strap, chin strap, to potentially something more sophisticated like a pneumatic device. I believe there's only one approved for head and neck, and it's the FlexiTouch by Tactile Med. But it's really important to kind of work so that you are trained on how to open the channels appropriate. A lot of people just think they can kind of massage down their neck, and it's a little bit more complicated because you have channels in your chest and your neck, and you want to make sure everything's open so you're doing it as effectively as possible. But if you have lymphedema after therapy, that's when we start. You can also develop lymphedema later, and if it's something that comes up, you know, always bring it up to your team. We typically see it right here most of the time. People call it, they'll come in and be like, I now have a turkey gobbler, or some kind of, that's what they call it. And so we typically know what they're coming in for. But if you can start it right after radiation, some people, that's about when they can start tolerating it, about 6 to 8 weeks after, based on how their skin's healing. So that's when we start.
Yeah, we have very similar practice in our practice as well. And I think, as Dr. Nilsen mentioned, there are several different options available, you know, massage, compression stockings, pneumatic devices. It's really important to work with a trained lymphedema therapist in just determining what's the best option for you, because it may not be, let's jump to the Cadillac, let's get you a pneumatic device, because there may be something that's simpler and just as effective for you in treating your lymphedema and fibrosis.
And there's a website you can use to search. If you want to search certified lymphedema physical therapist, it will help you identify people in your area, because some areas you may only have one. A lot of them work with breast cancer patients, but the principles are the same. So those websites are something beneficial. I'm not sure if we can give you the link somehow, but that could be a way to find somebody in your area, especially if you're not affiliated with a large academic medical center. And I'm in Pennsylvania, I'm in Pittsburgh, but we have them throughout kind of central, southwestern Pennsylvania. So they are available. You just may have to look a little bit, or ask your team, because they may also know.
And I think that's a great point. You know, I think it goes back to a question that was asked earlier about dental care. And I think lymphedema care kind of falls in the same boat. You know, I tell my patients, if they, you know, we see patients from 2-3 hours away. I'm also in Pennsylvania. And for a lot of our patients, they may have, one person that's a therapist in their region. I always advocate that you call their office first and make sure that you're someone that they can treat. Like Dr. Nilsen mentioned, breast cancer, a lot of lymphedema therapists do breast cancer patients for arm lymphedema, but they may not be comfortable seeing a head and neck lymphedema patient. And to save yourself the time of the visit, time of going down, doing the visit, and being disappointed, I always advocate calling the lymphedema therapist, calling the speech therapist, also making sure that they can they can manage someone who's post cancer surgery, cancer treatment, and calling your dentist to make sure there's someone that is comfortable and has experience in treating patients post radiation.
And it can be similar, I think, for just regular PTs. You know, a lot of the discomfort that you may experience after surgery or radiation is in your neck. And sometimes if physical therapists aren't familiar with head and neck, they may assume that it's a spinal issue or something along the lines. And so really having the knowledge and treating head and neck cancer patients previously is really helpful. So your team may have suggestions. We always try to make a recommendation if we see someone so that it kind of takes a little bit of the pressure off of you of having to find somebody. But you can always call an office and ask. And if you don't feel comfortable with the answer, you know, you can go on to the next.
Just another question on here that you maybe will answer, Dr. Nilsen, that is a good segue. It's asking about preventative lymphedema therapy to potentially prevent lymphedema post-treatment. So doing a pre-treatment.
Yeah, so I think a lot of, if patients are up to it, we will have patients meet with our lymphedema therapist or our PTs, one for just conditioning, like how can I maximize my movement during treatment, can I minimize some of those side effects. A lot of patients lose weight, so they get really deconditioned. So it is good, and you can talk with your PT and say, I'm going through radiation. Is there things that I can do? Because in addition to lymphedema, it's mobility of your neck and making sure you have, you know, you're turning, you're stretching, gentle stretching. And those, they can come up with a plan so that if you can't come in during radiation, you can self-manage, which is a lot of, not just during treatment, but after you're done and after you've completed. Self-management is a huge component. Being able to know what you need to do, kind of following it, doing it a couple days, a couple times a day in the beginning, maybe a couple times a week, and knowing if there's a change. So yes, get in, talk to your PT, talk to a PT, talk to your head and neck surgeons, make sure you're cleared, and your radiation oncologist, make sure they know if you're going to be treated that you're interested, because again, there are some preferences on whether they want you to do it or not, depending on if your surgery maybe didn't get all the cancer or what they see. Some may not want you to do it, so make sure you talk with your team. And obviously you need a script for PT, so somebody's got to write it. So just make sure they're aware of your intentions, but yes, you can.
I think that's it's an interesting question that actually I'm going to bring up. I know our lymphedema therapists and some of the therapists that we've spoken to are not keen on providing massage therapy or lymphedema therapy while there's concern for active cancer. So, I don't know if that's a similar thought process or paradigm that you use at Pittsburgh, but I'd say that's probably the one thing that I would say would be against doing any active therapy before treatment.
Yeah, so typically the people that we end up doing it in are people who have had surgery. You know, we believe we got clear margins. We've done a neck dissection. They either had no nodes in the neck, or we believe that we got everything. We don't see anything in the other side of the neck. So those are the people that they tend to be okay with doing it in the beginning. But if you've had surgery and you have positive margins, or you have not had surgery and you're going into radiation, that is typically when we tell you to hold off. There is not a lot of data to say that lymphedema therapy actually changes anything if you have active cancer, but people tend to be on the conservative side. So yes, we will do it in patients who tend to be clear after surgery, the margins are clear, the neck was clear, then they're more okay in that area. We don't typically do it if somebody has not had surgery and they're going straight into radiation.
Great. So we have about 3 minutes left for questions here, and I do see some good questions in this area. In the chat, I see that Ms. Hollander did put some back in the chat as well. Is carotid narrowing pretty much a given after radiation? I've noticed the variability in my practice in terms of what I see in terms of how narrow patients get. We do know radiation will cause vessel fibrosis, but the degree to which it causes it is just variable in patients for a variety of reasons.
Yeah, and I think the one thing that we do know is it does seem to be higher doses of radiation to the neck. You're going to be likely to have the potential for more kind of stenosis and changes as opposed to a lower dose to the neck. So that is the one thing. But it's variable, and even the rates of stroke after are fairly low. That doesn't say anything, especially if you have a stroke, like Chris and I have talked about. Saying the rates are low, but then having a stroke, it's not really helpful. So we do know there are some things, dose being one of them.
Yeah. Then the next question is about what doctor does carotid ultrasound. So that's variable. Some primary care doctors will do carotid ultrasound. Sometimes this can be a vascular surgeon or potentially a cardiologist. But by no means are we saying that you need to have a carotid ultrasound done. It's going to be a discussion with your oncology team, your radiation team, the surgeon, in terms of what the particular risk factors or necessity for you would be.
Yeah, and I talked to you again. Keep your primary care doctor in the loop. We hear it's some of our neurology, stroke, neurodiagnostic team does them, but we have a stroke institute, so that's kind of what they're connected with. But talk to your providers, your team, see your risks beyond head and neck cancer, and discuss whether they think this might be beneficial.
I'm just going to highlight a comment that Jason McAdoo mentioned. He's a nurse navigator, and I think what he wrote in here is awesome. And it's what a lot of our nurse navigators do as well is to help facilitate transitions of care to therapists, to speech language therapists, lymphedema therapists. Is they'll call the therapist themselves to see if the therapist in the area can help them out, so that way they can find care closer to home. So that's excellent. Thank you for mentioning that.
Yeah, so I'm a nurse. I have my PhD, but a lot of what I do and what we set up is so that we do the work for you. So you don't have to, find these providers, that we can make the recommendations. We try very hard to schedule or help or have these offices even reach out to you so that they're minimal. So nurse navigators, nurse coordinators, a lot of these teams are really poised and ready to help.
All right, so it looks like it is now 6 o'clock. I know there were several other questions that were in the chat here. I'm sorry that we're not able to answer all of them, but we do appreciate your time and joining us in this conversation about survivorship. Ms. Molnar, I'm sorry, I know you were having some sound issues at the end and weren't able to participate in some of the Q&A session here. And everyone, we appreciate your time and thank you for joining us today.